Good morning, I'm Jessica Lovell, and welcome to the Morning Medical Update. Over the past few years, we have shared dozens of transplant stories on this program. Whether it's kidneys, heart, liver, or even stem cells, transplants are amazing gifts that have the power to save lives. Today, we are learning more about a lesser known and seemingly unusual kind of transplant. That is a transplant involving another person's waste, also known as fecal microbiota transplants, or FMT, as we'll be referring to it today, when someone else's waste becomes the treatment. There's kind of an ick factor, we understand, in today's discussion, but as you will see, these transplants can also be very life-saving. So I'm joined today by Courtney Walker, who received an FMT, along with her doctor, Dr. Shadi Hamda. He is a gastroenterologist here at the health system who performed Courtney's transplant. Good to have you both here. Courtney, how are you doing, and how's it like to be here with your doc?
It's great. I'm so glad he came on to help me talk about FMT.
Well, and to talk about this journey in your health, with your health journey, because you've been on before, and we appreciate you coming back to share even more. So
I'm so glad to be back.
Very interesting, interesting topic. Because yeah, you were here. This was your donor, and now you're, what do you call, your bestie now, right?
She's my kidney sister.
She's your kidney sister. It was so great to have her on, and we learned about this rare kidney disease that ultimately led to that kidney transplant. But before that, you could get that transplant. We're going to learn why you needed the fecal transplant in the first place. Courtney needed it to treat a reoccurring C. diff infection. Before we jump into our discussion, I'm going to let Chief Medical Officer Dr. Steve Stites explain what C. diff is and how it can take over our GI system.
Inside your gut, there is a complex system of millions and millions of different kind of bacteria, which we call microbes. And it's really important because those microbes, those bacteria, they help us with digestion, absorbing our food, how we form our stool, and how we stay healthy. Because in a healthy person, that microbiome, that collection of different kinds of bacteria, it is very well balanced. And it happens to you right after you're born. But antibiotic medicine, like some patients can get in the hospital, or maybe you take for a cold or bronchitis, etc., can upset that balance. And when that happens, there's this one kind of bacteria called Clostridioides difficile, or C. diff, and they can take over. And the challenge is that when C. diff takes over, it can make you feel really, really sick. You can have chronic fevers, weight loss, lots of cramping and watery diarrhea. You can have 10 or 20 stools a day. C. diff can make you feel really awful, and sometimes it can take your life. Certain antibiotics fight C. diff, but C. diff has this habit, and it's a bad habit, because it rebounds and it keeps coming back again and again and again, and sometimes it can become resistant to the different kinds of antibiotics. When we get into that type of spiral, we have to take some more drastic measures. We're going to talk about some of those today.
And the drastic measure that Dr. Stites mentioned is FMT. We heard that big explanation. We're going to kind of break it down today. Dr. Hamda, kind of give us more context of what this is. We know there's countless different bacteria in our GI system, but what makes C. diff dangerous?
First of all, thank you for having me here, and I'm so excited to be with you guys to talk about C. diff, about this epidemic. So, as Dr. Stites mentioned in the report, so our gut microbiome is a dynamic ecosystem, and every person's gut is actually is a home of trillions and trillions of microbes. The most of them are beneficial. So we have actually good bacteria and bad bacteria. We call them actually, to make it easy for the audience today. So the good guys, we have the good guys and the bad guys. They live together in harmony to keep us healthy. And when the balance is disrupted between the good and the bad bacteria, and actually this is when we have actually diseases. So when this balance is disrupted by taking antibiotics, so the balance actually can be disrupted by taking antibiotics. As I said, this is the most common cause of having, C. diff or any other opportunistic infections in the gut. So this can happen either when the good guys are eradicated by taking antibiotics, or sometimes even when the bad guys actually when they get actually stronger. And actually, in this situation, like in patients who are immunocompromised, patients with underlying some immunocompromising diseases, like patients with cancer taking chemotherapy. So again, when we have this balance disruption, actually, this is when we start to see increased risk of opportunistic GI infections, including C. diff.
So in a healthy person, is it the good guys keeping the bad guys in check?
This is exactly true. Again, we have to reach this state of balance. When this is disrupted, actually, the state of balance is disrupted. Actually, this is when we start to see actually some problems. So talking about fecal transplant, actually, this is a very safe, effective, and actually helpful way actually that help our patients with C. diff. And this is by restoring the healthy microbiomes. Actually, we can actually transfer the feces, actually some screened feces from healthy individuals to the colonic lumen actually of patients who have C. diff. Actually, this helped us actually to restore and repopulate the gut for these patients.
So once this balance, as you said, gets thrown off, how hard is it to reset? And what other options are there than this fecal transplant that we're going to talk about?
That's a good question. Actually, it's for most patients. Actually, it does take about 1 or 2 months actually for them actually to completely recover this actually their original actually microbiome. However, for some patients, it might take longer time, especially for patients who are on long-term antibiotics. So sometimes patients with long-term antibiotic use, or patients actually with underlying cancer malignancy using chemotherapy, it might take a longer time for them actually to restore their microbiome.
So Courtney, C. diff put you in the hospital 6 times, starting back in 2017. Do you have any idea where this started?
Each time I have had an occurrence of C. diff, it's been from antibiotics from another infection. In 2017 and 2019, those were the causes. What started happening between 2022 and 2023 was once I got C. diff, I could not get rid of it. So I was hospitalized 4 times from November 22nd to March 2023, getting sick and then getting reinfected. Getting sick, recovering, getting reinfected.
Dr. Hamda, is that typical to have it just continue to reoccur back to back to back?
So recurrence is not abnormal actually, or it's not uncommon. So about 20% of people can have, even actually the risk of recurrence might be higher than 20-30% in patients with inflammatory bowel disease. So this is my specialty. So I treat patients with inflammatory bowel diseases. So I see patients with Crohn's disease, ulcerative colitis. The recurrence rate might be even higher, 30-50%. So it's not uncommon to have a recurrence in patients with C. diff. So let me tell you this actually. Now, when we think of C. diff, we think about the pre and post 2000. Before 2000, when we used to see patients with C. diff, we didn't have recurrence. It was easy to treat C. diff. We give them antibiotics, C. diff goes away, and we do not hear back from our patients. In the post-2000 era, C. diff actually has become more refractory, more actually resistant to treatment with antibiotics, and this is why actually our guidelines have been updated multiple times. So we start actually first back in the days actually we started with medication called metronidazole. The updated guidelines now we have vancomycin, fidaxomicin, and now we're talking about C. diff. So again, post 2000 actually our C. diff bacteria has become more resistant.
Why?
That's a good question. Actually, a lot of reasons could be actually because of the increased use of antibiotics that we are seeing in the community. A lot of other factors, actually, the increased incidence of malignancy. So again, patients who are immunocompromised, we are seeing more patients who are immunocompromised. This itself also can increase the risk of the refractoriness of C. diff because of change in the microbiome of these patients.
So is it fair to say that Courtney's history of Crohn's and that previous bowel resection put her at a higher risk?
That is absolutely correct.
So is it fair to say, though, that C. diff would come from something that a patient would already know they have, meaning C. diff has been something that a physician has said, hey, this is something you're at risk at, or is it something they could have, not know it, and need to be looking for signs and symptoms at home?
So this is actually a very important point. So about 10% of the population actually are colonizers for C. diff. So you don't necessarily have to have symptoms. So C. diff, you can have C. diff in your gut actually without having any problems. You remember when I talked about the balance. When the balance actually is changed, when the state of balance is changed between the good guys and the bad guys, actually this is when C. diff can become toxigenic, and this is when it can cause symptoms by producing a toxin. So for patients with inflammatory bowel disease, there is about 5-fold increased risk of C. diff for IBD patients. About 10% of patients with IBD can have C. diff infection. And once you have C. diff and IBD, actually the chance of recurrence is higher. You remember when I was saying 20 to 30% of patients can have the risk of recurrence. In IBD patients, this risk can be up to half. So about 50% of patients can have recurrence, and also the morbidity and mortality. So more patients actually with IBD, when they have C. diff, they are sicker, and the risk of mortality, even patients dying from C. diff if they have IBD, is higher. So if I give you the statistical numbers, about 1.4% of patients can die community-acquired patients with C. diff can die from C. diff, however, 3.3%. So it's over double percentage of patients can die from C. diff if they have underlying IBD.
Well, this woman across from me, she's always smiling, even when we talk about all of this that she has gone through. And hearing Dr. Stites and you describe it, it sounds awful. I have to just say, from where I'm saying it sounds awful. So Courtney, don't hold back. Tell us what it was like day to day, and how did you push through all this?
When this last round, 22, 23, I was really not even well healthy at the beginning because my kidney function wasn't doing well. But getting C. diff sort of in November of 22, you just don't feel like doing anything. You go to the bathroom all the time. You never want to stay far from it. You want to, if you eat, it goes right through you. If you do anything, and then on top of that, you're also always cleaning up after yourself because it's so transmittable to other people that you have to constantly be bleaching and cleaning and taking care of, like, you staying clean. And then the other rest of the time, you're going to the bathroom, you're sleeping, or getting ready to go to the bathroom, or having cramps, or crying on the floor.
Yeah,
it's not something you'd wish on your worst enemy.
And you just fought through it. But that's an interesting point, Doc, that she brings up, just about keeping the people around you safe. And let's be honest, when we're living with a family, we don't really think about disinfecting all the time. We all go to the bathroom and we're all cooking and nobody's really thinking about it. I'm sure my kids don't wash their hands all the time. Let's be real. So how important is it, though, when you are living with somebody who has this, is keeping other people safe from it?
It is very important. As you said, actually, it's not uncommon to see actually that the family members, actually, the household holders of patients with C. diff, actually, they can be carriers of C. diff themselves. So this is very important. Actually, C. diff, if we go back to the nature of C. diff, actually, it's a very strong bacteria. So C. diff actually has a coating. It has actually an outside coating. It's very severe. Actually, it's very resistant to be killed by using heat, by using actually like stomach acid, also antibiotics. So that's why actually C. diff is refractory to most of the antibiotics we have. It's only 3 antibiotics that so far have worked for treatment of C. diff. So that's why actually in the hospital, when our patients see us, actually we put on the gowns, and actually we wash our hands, because C. diff actually cannot be killed with the alcohol sanitizers. Actually, we have to use actually the soap to get rid of this, to get rid of the spores I was talking about. Yeah. So it's very refractory. It's very resistant, and it's very resistant. Actually, it's very important to wash our hands after we see C. diff patients.
Gosh, okay.
It's isolating.
Isolating, yes.
It's a very isolating sickness.
Well, and it's not one that's comfortable to talk about, clearly. I mean, people talk about...
You don't cancel on your friends and say, oh, well, I have a round of C. diff. I can't make it out. You can't really say, well, I can't get off the toilet.
Right, right. And I understand there's a distinct smell. Is that, I have to ask, distinct more than what we would normally expect? I
say sweet, sour, and very foul.
Okay.
So like a sweet foul.
Yeah, that is very correct, actually, and this is something we hear from our patients. Actually, they say it's unusually, strong and also sweet, as you said. I hear this from a lot of my patients, and the reason actually behind the odor of C. diff is because of the increased bile acids in the stool of C. diff patients.
How can someone end up dying from this infection? And let's just be honest, was Courtney hovering anywhere near that?
So yeah, as I mentioned, actually about 1.4% of patients actually can die, again, if they have underlying risk factors, if they have actually more risk factors for having severe disease, as I say, patients with malignancy, patients with IBD, actually, so they can even die more. So they can die from complications of the disease. So patients actually with C. diff, they can have complications. One of these complications is called ileus. Ileus actually is the lazy bowel. So when there's small bowel can be distended for a longer time. Also, sometimes actually the colon can get distended. Actually, when it's significantly distended, we call this condition toxic megacolon. So toxic megacolon, when there's a lot of air in the colon, it can get perforated. It can cause a hole in the colon. Actually, this is how people can die. And some other actually ways actually people can be affected severely by C. diff. Actually, if it affects the receptors, the vascular receptors in the body, and sometimes actually can cause a shock or drop in the blood pressure. By causing a shock, the perfusion actually will diminish, will get diminished actually for the vital organs in the body, and actually this is one of the other ways actually C. diff patients can die.
So C. diff obviously hurting her kidney function.
This is actually true. Yeah. So yeah, the perfusion. When I was talking about the perfusion, it can affect any of the organs, the vital organs, including the kidneys. So yes, and actually this is why actually we have to take it actually more aggressively in the case of Courtney, and we have to think about like out of ordinary options for her.
So, Courtney, in late 2022, you were trying to get approved for this kidney transplant. You were also fighting C. diff at that time. Is that right?
Well, in August of 2022, I was approved for kidney transplant, and I was placed on the list, the big world list.
Yeah, the waiting list. Yes.
And so that was August, but I wasn't in a position GFR-wise to be like ready to do transplant. Starting in November and having repeated transplants, my kidney function went down about 10% into where it's end-stage renal failure by the time I got to April. That's where my kidney function was. So they needed me to get the FMT so that I could actually go through with the kidney transplant.
You needed to be healthy enough to get the kidney transplant.
Yeah. So I was under the gun. And that's why when I went to the Mayo Clinic and I got a second opinion and talked to some of the doctors there, because you are your own best health advocate. And I felt really comfortable after speaking to them and hearing about it. And fortunately, Dr. Hamdo was ready to perform it before even Mayo Clinic was. So
here you are waiting for one transplant. Then
kidney transplant.
Then you get introduced to a new type of transplant, this fecal transplant. What were you thinking when you heard about this? I mean, most of us, I'm sure you've done the deep dive and know all the details, but most people will go, what?
Well, yeah, and you're literally just ticking off things off a checklist to get to the end goal, which is transplant. So I'm looking at it, I'm thinking, okay, well, this is the way to get the kidney. My kidney function is already decreasing. This is the best thing I can do to be prepared when Gina is ready to donate her kidney.
Yeah, Gina, your donor.
And to me, it was just part of the process. There were so many things. I'd already spent so many days in the hospital. I'd already had 4 infections in 4 months, 5 months. I couldn't do anything in life. So when someone hands you a lifeline, and then your team here at KU, which is my favorite team, I got to come back here and have the C. diff transplant here, or the FMT here.
And you were on dialysis, right? Is that correct?
I escaped dialysis.
You escaped dialysis.
I was one of those very fortunate people that by doing all of this homework beforehand and really knowing what I needed to do, I really stayed away from dialysis.
Okay, but you're very clinical now because you've been in this medical world and you're like best friends with all your doctors and you know everything. But for the rest of us, when we talk about a fecal transplant, you got to go back and tell me what you thought, because most people are like, okay, we're going to take waste from some random person and it's going to help you get better. I just help us make that connection, because that just sounds wild to most people.
My biggest fear was that if I didn't do it, I would end up on dialysis. The gross part was, it is a gross idea, except that when it's in the way that they explain it, the way that this is the procedure goes, I'm not watching stool go into my body. I'm asleep. It's a colonoscopy, and it's sprayed into my system.
And it's saving your life. So that kind of supersedes everything, then the gross.
So after 4 months of not being able to make plans or do things or live, that it was gross, but at the same time, it was a gateway to the other things of life.
Yes.
And you just rectify that and you move on.
So you're on the receiving end of this, but we need donors. So where do these donors come from? How do they even know that this is a possibility?
That's a very good question. And now we have a very strict criteria to choose from the donors. So in 2012, MIT, the Massachusetts Institute of Technology, actually found this, the Open Biome, which is the first stool bank in the U.S. And after this, we have multiple banks throughout the U.S., including in Kansas City here. So now these donors, again, they have to go through a very thorough and careful examination to pinpoint which candidate can be chosen for stool donation. So these patients actually, again, first actually they have to talk to the doctors to actually make sure that they qualify for the stool donation. There are some criteria for that. First of all, actually patients should not have received any antibiotic exposure for the past 3 to 6 months. So again, they have to have actually healthy microbiome, and also they have to be actually not immunocompromised. So they have to be healthy donors, not immunocompromised. And also we always check for actually we check for any infections in the stool. So we check for hepatitis A, B, and C. We also check for syphilis, for HIV, and we also check for any GI conditions. So patients who have actually underlying GI conditions, chronic conditions like inflammatory bowel disease, again, these patients actually will have abnormal microbiome. So usually they cannot be actually donating stool. And also patients with underlying malignancy, patients on chemotherapy. So again, it's really very thorough, process until we choose our donors for the fecal transplantation.
Okay, is this one of those moments where you meet the donor? Because of course we know Gina's your donor, but would you know where your fecal donor came from or who they are?
My fecal donor came from the Rochester Stool Clinic in Rochester, Minnesota. I have no idea who they were.
So there's just a database.
Yeah, so we have actually now the national registry. So again, the first open biome came from Boston, but now actually we get most of our stool samples from Rochester. So there is the database in there. Actually, this is where we get our our stool, as I said, stool samples. So, but to mention actually, we talk about the national registry. Actually, this is very important. Actually, national registry. Now we are reporting our outcomes to this national registry because it's important to help our our future impact of fecal transplant. And again, we can learn more about the side effects of the stool, about the fecal microbiota transplantation. At this time, we feel it's very efficacious, but also very safe. We have not seen a lot of complications with C. diff. But by contributing more, by actually applying more to this national registry, by sending our data, actually we can help the future of fecal transplant.
All right, show and tell time. So we have some video of fecal transplant happening.
Okay.
The product is treated pretty much like any other medicine, Doc, right? Transplant happens during the colonoscopy, Courtney, as you had mentioned. But I guess there's more than one method for FMT. How does this colonoscopy method compare to others?
That's a very good question as well. So colonoscopy is the most commonly used procedure for the fecal transplant. So this is actually easy. It's very similar to the screening colonoscopy. So patients have to go through the colonoscopy prep the day before. After this, we do the colonoscopy. We insert the colon. We insert actually a scope, which is a camera on the top of the tube. We go all the way to the right colon, sometimes to the end of the small bowel, and we infuse the fecal material. Sometimes actually we can give also like fecal transplant through enemas, so the patients do not have to prep for that. And also the other ways actually of doing fecal transplant is by doing an upper endoscopy. So we go from the mouth all the way down to the stomach. We pass the stomach and we start to infuse actually the fecal material in the duodenum, which is the first part of the small bowel. And nowadays we have capsules for for fecal transplant as well. That is approved by the FDA in 2023. So I have a lot of methods, but again, colonoscopy is still actually the most commonly used method for the fecal transplantation.
But developing in its ways to be administered. If you're watching live and you have questions, use the chat on YouTube or Facebook. You can email the Medical News Network. The information is right there on your screen. So Courtney, you have the FMT. Did you notice symptoms improve, and how soon after?
Yes, probably 2 or 3 days. I just stopped having symptoms. It was more as in having less symptoms, not having cramps, not having diarrhea, not having that. And it really, after having a colonoscopy, it's not really like there's a complicated follow-up pain. I guess if there was an issue with the colonoscopy piece of it, but when I left, and I had just a regular life. I really, after FMT, you can't take antibiotics for 90 days. So I was very careful in my situation because I was trying to get a kidney transplant to stay healthy to that point.
So are you one and done, or is there a reason why somebody might need another one?
So yeah, some patients actually can require multiple fecal transplants, especially patients, as I said, with risk factors. When I talk about IBD patients with cancer, because although we are trying to restore the microbiome, it can change again, and this is why I mentioned actually about IBD patients, the recurrence rate is 50% without C. diff, without fecal transplant. So even by doing the fecal transplant, some patients might require more than one. So some patients might have 2 or 3 transplants, but the chance that patients are going to respond to fecal transplantation goes up and up with every subsequent transplant.
So I have to ask you about the controversy of how folks are classifying FMT. Some say it should be treated like a blood or tissue donation, others as a new drug. Why the dispute?
So I don't know if we can classify fecal transplant as a transplant or even actually medication. So first we have to do the screening process. So it's treated as any transplant process. So we have to do the screening part. So in that part, it resembles actually transplantation. However, we don't have to be on long-term medication. So we do not have to monitor patients. They do not get actually any immunocompromising medication. So it's not necessarily a transplant, but it's also actually treated right nowadays as a drug because again, we can watch for the long and the short-term side effects. So again, at the beginning, we treat patients when we screen them as transplant patients, but again, we do not have to monitor them on the long term because we do not start them on any immunocompromising medications, and in that situation, we treat it as a drug.
Could FMT be used to treat other conditions now or down the road?
That is an excellent question, actually. So FMT, when we started doing FMTs, actually the first one of the landmark trials in the FMT field happened in 2013, and actually in that one, actually when we were comparing actually FMT or fecal transplant to vancomycin, the results actually were 96% versus 31%. So the study actually had to be terminated early because it was unethical, because one arm actually was much superior to the other arm. So fecal transplant actually was way more superior to vancomycin. So this way actually we got so excited and we said, okay, let's try C. diff for other conditions. Like we started actually studying this for ulcerative colitis, IBD, and name any disease you think of. Actually, we have done this actually for multiple diseases, including epilepsy, seizure, like coronary artery disease. So far, the best results we have had for C. diff, for FMT is for C. diff, for recurrent C. diff patients. So the guidelines changed actually recently in February 2024. Actually, the AGA guidelines were updated, and now C. diff is recommended for recurrent C. diff. And by recurrent, actually, they have to have more than 2 episodes of C. diff. So they have to have at least 2 recurrences or 3 episodes to be qualified for C. diff. And now the guidelines also added patients with C. diff if they do not respond to therapy. If someone is really sick in the hospital, if they do not respond to antibiotic therapy within 3 to 5 days, this is when we also start to think about FMT for these patients.
Let's get to some questions from our viewers. Jeremy wants to know, there was a comment about the bile levels with C. diff. Would having your gallbladder removed affect the severity or anything with C. diff?
That's a good question, actually. There are no studies that have shown this. So we follow evidence-based medicine, and so far we don't have any evidence that having cholecystectomy or removing of the gallbladder can affect the outcomes of C. diff.
So remind us before we let you go, what does someone need to do? What questions do they need to ask, or where do they need to go online to find out if they can be a fecal donor?
So that's a good one. There are actually nowadays a lot of stool banks that they can go to. There are a lot of websites. Actually, if they don't have actually the resources, they can reach out to their doctors. At KU, actually, we have some resources for our patients. So again, there are a lot of websites nowadays they can register on to be a stool donor. Again, they have to go through a lot of screening process. It's a very exhaustive screening process. And I want to remind our patients who are willing to be donors, because sometimes actually this might not be covered by insurance. So they might have to to be responsible for over $500. So they have to check. They should check with their insurance before actually they go with the student donation.
So they actually might have to pay to do it.
They might have to pay. Again, they have to check with their insurance if this is covered or not.
Okay, but it's not like a blood bank where you just walk in and roll up your sleeve. There's a lot more hoops to jump through.
A lot of screening process, yes.
But well worth it if you can do it.
It is so worth it, yes.
Yes, as Courtney can attest.
My daughter actually went through the process of trying to be a stool donor, which is funny since I have Crohn's disease. But it's if you are able to donate stool, you get paid handsomely for your stool because it's that precious.
As you should be, right?
Yeah, I mean, hey,
worth every
side
penny.
gig.
Yes. That's good to know, though, and it might entice people to look into it. Courtney, what's the big takeaway from your story? What do you want people to know?
I think I said this before in February. I'm going to say it again. You are your own best health advocate. You have to go out there, do the research, look around, talk to your doctor, talk to your nurses, and look at white papers, valuable sources, get the second opinion. I would just say to people, once you mentally get over the thought of what you're actually doing, I think I actually have the gut biome now of like a 25-year-old.
Nice.
Yeah, I was like, maybe I'll get less wrinkles.
That's gonna feel good, though. Yeah. Just turning it over.
But I mean, you can look at it both ways. But I always say, go learn and know everything you can about what your condition and how to solve it.
Well, and we appreciate you being such a good, just your advocacy and about yourself, and then sharing it with other people to say, don't be afraid to research it yourself and ask all the questions. Dr. Hamda, what's the big takeaway?
So, I want to say actually C. diff is definitely in the rise. Actually, now we call this an epidemic. We are seeing increased incidence of C. diff in the community and also in the healthcare setting, increase about 43%. So I want to remind our patients that fecal transplant is now available. It's safe, effective. It's very effective, in fact, and we are ready to receive any cases. Actually, if someone actually needs actually to transplant, our team at KU is equipped to see these cases. Actually, we can see them as soon as possible. We have received, I would say, over the last year or so, we have received actually multiple referrals from all the surrounding states. So I've done cases from like Kansas, Missouri, Arkansas, Oklahoma. So if anyone needs C. diff, actually, we're happy to see them at KU and try to expedite the process as quickly as possible.
Well, thank you both for educating us on it so people know that it exists and know where to come. So thank you both. Thanks to our guests. Thanks to our viewers for being with us today. We'll see you back here on Wednesday.
Coming up Wednesday on Open Mics with Dr. Stites. A fireworks display goes terribly wrong, leaving one woman severely injured. I'm Alexis Del Cid. On the next Open Mics with Dr. Stites, we hear her story and step into the operating room to see the advanced techniques that reduce scarring and add new skin to patients. Wednesday at 8 a.m.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcast. Now, everywhere podcasts are available.